I'm Gloria Iacoboni, a hematologist at Vall Hospital in Barcelona, Spain. I'm really happy to be here today with you, sharing our data on zamto-cel, a tandem CD20, CD19 directed CAR T cell therapy in relapsed refractory large B-cell lymphoma, crossover analysis, so third line from the randomized pivotal DALY2 EU trial. So we know that CD19 targeted CAR T cell therapy has revolutionized the prognosis of patients with relapsed refractory large B-cell lymphoma. And we have randomized trials exploring the role of CD19 targeted CAR T cell therapy for transplant-eligible patients. However, the level of evidence for CAR T cell therapy in a transplant-ineligible setting was still lower compared to the transplant-eligible patients, and that's where zamto-cel performed its pivotal DALY2 EU trial, which I will be sharing with you today. So just to set the stage, zamto-cel is an autologous, non-cryopreserved, this is an important feature, tandem CD20, CD19 directed CAR T cell therapy with a fixed 12-day manufacturing window and an average vein-to-vein time of 14 days. In this randomized pivotal trial, zamto-cel was compared with standard of care, mainly R-GMOX or Pola-BR in a small group of patients, in a transplant-ineligible setting, relapsed refractory large B-cell lymphoma. So these first results were presented at ASH 2025 by Dr. Borschman, and zamto-cel showed a significant improvement in event-free survival was the primary endpoint compared with standard of care, which was mainly R-GMOX in transplant-ineligible relapsed refractory large B-cell lymphoma patients. In these initial data, zamto-cel showed a manageable safety profile with low rates of grade 3 or higher ICANS, 1.3%, and cytokine release syndrome, or CRS, 5.3%. Now, the aim of our current study and data, which was presented at EHA 2026, was to evaluate the efficacy and safety of zamto-cel for crossover patients from the standard of care arm in this DALY2 EU trial. So as I've explained, the main study design was this randomized kind of structure, and a protocol amendment in February 2023 allowed a one-sided crossover from standard of care to zamto-cel as third-line treatment. No crossover occurred before that amendment. So to be eligible, patients had to have relapsed or progressed within 1 year after randomization, or had failed to achieve a PR or partial response in over 8 weeks, or CR at end of treatment, and the start of a new anti-lymphoma therapy was warranted. So these were the criteria to allow crossover from standard of care with R-GMOX mainly, or Pola-BR in a smaller group of patients, to the zamto-cel arm, and therefore be eligible to receive zamto-cel as a third-line treatment. Leukapheresis, and this is important, the leukapheresis product was collected after randomization and prior to standard of care, or after the first cycle of standard of care. This was also allowed. Crossover patients received a target dose of zamto-cel, and in this case, in this crossover patient population, bridging therapy was allowed. So in terms of the results, just to highlight, 100 overall, 168 patients were randomized to zamto-cel, 82, or standard of care, 86. So a total number of 168, 82 received zamto-cel in second line, 86 received standard of care. Of the 51 out of 86 patients who received standard of care and had provided informed consent following the protocol amendment, 31 were eligible for crossover, and 29 finally received zamto-cel as a third-line treatment after crossover. We've talked about the crossover criteria, and just to highlight, only 29 received zamto-cel out of the 31 who were eligible for crossover, because one patient withdrew informed consent, and another patient unfortunately died due to progressive disease. So it's interesting to highlight some of the baseline variables, which were quite similar to the overall patient population, and understand that 4 patients received a cryopreserved product. So if bridging therapy, which was allowed in this patient population, was intended, cells were cryopreserved and then were manufactured and infused fresh after manufacturing. In terms of safety, and we'll start out with that, neutropenia was the most common hematological treatment-emergent adverse event with a 55.2% rate. And in terms of treatment-emergent adverse events leading to death, this occurred in 4 patients, so 14%. However, to highlight malignant neoplasm progression, that meaning lymphoma progression, was 2 out of these 4. The other 2 were bronchitis and septic shock. In terms of CRS and ICANS, overall rates were 48% for any grade CRS and 17% for any grade ICANS. If we want to kind of, break down the different gradings, so we mentioned CRS any grade 48%. This accounted for grade 1 in 28%, grade 2 in 14%, and 2 patients, so 7%, had a grade 4 CRS. So if we're talking about grade 3 or higher, 2 patients, 7%. In terms of ICANS, we mentioned overall any grade 17%. And in terms of the different gradings, grade 1 in 2 patients, 7%, grade 2 in 2 patients, 7%, and grade 4 in 1 patient, 3%. Finally, in terms of efficacy, median follow-up was 7.9 months, so still a bit short to look at survival outcomes. But in terms of response rates, a complete response was achieved in 66% of the patients, partial response in 14%. 10 patients experienced progressive disease as their best response to this crossover zamto-cel infusion, and 1 patient, 3%, experienced a stable disease. So in conclusion, in this third-line setting, most intended patients received zamto-cel. An analysis of this mainly refractory third-line patient population revealed clinically meaningful efficacy of zamto-cel with low rates of severe CRS and ICANS, consistent with the second-line treatment results we've already observed with zamto-cel. So I hope you enjoyed this presentation, and thank you very much.